Good afternoon. It's good to talk with all of you. You'll notice if you look at the first slide that's up here that I've changed the title. We were specifically going to talk about neonatal abstinence syndrome, but we had several requests coming in asking if we could at least take a brief look at whatever information is available as to the long-term outcome of children prenatally exposed to opiates. We're going to look at this from a much broader view, in that we're going to go from neonatal abstinence syndrome all the way through to the neurodevelopmental outcomes of the children long term. Before I get to that, though, I thought we should take some time to try to understand why our current epidemic of opiate use is unique. And to do that, I want to go back in history. If we look to the early 1800s, a pharmacist, Nathaniel Chapman, published some articles that held up opium as the most useful drug that physicians could use. He said, to quote, "There is scarcely one morbid affection or disordered connection that would not respond to this wonder drug." And it was in the early 1800s that the first development of morphine came forward. So with that kind of an endorsement and morphine now being available, it's not surprising that the use of opiates began to really expand. And by the 1840s, opiate dependency was recognized as, quote, a problem for society. This was held up during the Civil War. The best data we have shows that about 10 million opium pills and about 3 million ounces of opium powders and tinctures were distributed during the Civil War. But then the big changes came in the 1870s, and this is when hypodermic administration, that is, use of opiates through a needle, injection into the vein, became available. And Courtwright, a physician, reported that hypodermic administration of opium provided near instantaneous relief. This is what led to the widespread addiction that began occurring. And by the early 1900s, 1919 specifically, there was an epidemic of opiate use. And some studies then were very interesting in that researchers looked at the question, who's at risk for being addicted to opiates? And they found the main factor that predicted an individual's opiate addiction was that if they went to a prescribing physician who was more than 50 years old. The other big change, and what has most directly affected our current situation, is that during the 1980s, federal legislation changed that began to allow direct advertising to consumers. Prior to the 80s, the early 90s, if a pharmaceutical company wanted to advertise a medication, they were allowed to advertise only directly to physicians. At that time, the federal government changed the legislation so that pharmaceutical companies could advertise directly to consumers. And one of the first drugs that was advertised directly to consumers was OxyContin. OxyContin was developed specifically for post-surgical pain. But if you turned on television, if you turned to a magazine or newspaper, you saw advertisements that said, if you're having headaches, if you're having pain, talk to your physician about OxyContin. And this is really when our current epidemic had its roots. Fast forward to the current situation, and when we look at the 21st century and our current opiate crisis, we find that there are, again, special populations that are at risk for receiving opiates. The first are populations that report undertreated pain. Now, of course, undertreated pain is very subjective, and it takes a patient reporting to his or her physician that the pain is not helped by current medications. And so there is a collaborative participation between patient and physician as opiate administration and doses continue to increase. The other population, surprisingly, in this modern age that is at risk for receiving opiates is women, especially associated with menstrual cramps, and then also military personnel. So these are three populations that have been specifically at risk for getting opiate prescriptions. Some of the current studies have looked at narcotic prescription use, and specifically, since we're talking about pregnancy, I want to mention an article, some research that looked at use of narcotics through prescription for more than 1 month during pregnancy, data from 1998 versus 2008. In 1998, for every 1,000 deliveries, there were 2.5 cases of women using narcotics by prescription for at least a month during the pregnancy. Whereas fast forward to 2008, that number goes from 2.5 to 10 cases per 1,000 deliveries. So you can see that the rate has quadrupled. Looking at it from another direction, the Tennessee Department of Health reviewed 805 cases of neonatal abstinence syndrome. And they looked at the infants going through NAS. They looked at the infant's mother's history of use of narcotics during the pregnancy. And what they found was that only 28% of those cases were using narcotics illicitly. 72% of the cases had prescribed narcotics during the pregnancy, resulting in the infants going through neonatal abstinence syndrome. Now, the medical implications have been quite well known for a while. Babies whose mothers use opiates prenatally have increased rates of low birth weight, low birth length, small head circumference, which obviously has significant implications for long-term development, stillbirths, and sudden infant death syndrome. More particularly, though, what our attention has been drawn to is the high rate of neonatal abstinence syndrome. Now, let's be very clear about what NAS is. NAS is a combination of the signs and symptoms that occur when a newborn prenatally exposed to opiates experiences opioid withdrawal. Now, we have to be careful here because there are many people that will look at an infant having neurobehavioral difficulties due to prenatal cocaine exposure, prenatal tobacco exposure, and they will call that neonatal abstinence syndrome, when in fact, opiates are the only substance that produce true neonatal abstinence syndrome. Now, we should mention that tobacco and barbiturates have also been shown to cause some type of withdrawal, but neonatal abstinence syndrome specifically refers to opiates and the accompanying opioid withdrawal. Now, the most recent data we have said that neonatal abstinence syndrome occurred in anywhere from 2 to 11% of exposed infants. However, that is very old information, and we do not have any current data as to the relationship between NAS and maternal use of narcotics. We are all well aware of the incidence of NAS going up. If we look at data from two separate time frames, 2004 versus 2013, we can see the rate of neonatal ICU admissions per 1,000 admissions due to NAS went from about 8 per 1,000 in 2004 to about 28 per 1,000 in 2013. The length of time the infant stayed in the NICU also increased from about 12 days to a median length of stay of almost 20 days. The percent of NICU days attributed to NAS went from less than 1% to about 2 to 3%. And the percent of infants who needed medication due to neonatal abstinence syndrome in 2004 was about 75%. In 2013, about 88%. So any way you look at this, you can see that NAS is having a significant impact on healthcare of the newborn infant. This, of course, contributes to increasing costs. From 2009 to 2012, neonatal abstinence syndrome costs went from $732 million to $1.5 billion per year. And be aware that 81% of those cases are paid for through Medicaid. Geographic distribution is highest with about 16 per thousand live births in the middle states such as Kentucky, Tennessee, Mississippi, Alabama, and the lowest rates of about 2.6 per thousand live births occur in Oklahoma, Texas, Arkansas, and Louisiana. Now, these data are from a couple of years ago. It's going to be important to track this because, as you can see, Kentucky, Tennessee, Mississippi, Alabama are almost contiguous to the states with the lowest rates. And one would wonder if these high rates are not spreading into these rates that at this time of the report had the lowest rates. Now, what exactly is neonatal abstinence syndrome? It can be present at birth, or it can occur as late as 24 hours after delivery. It really depends on when the mother had her last dose and what her pattern of use was, including the amount she was using. Neonatal abstinence syndrome usually peaks at about 3 to 4 days. And back in the 80s, we wrote an article that demonstrated that the acute phase of neonatal abstinence syndrome lasts about 6 weeks, with the subacute phase and lessening of symptomatology going through about 7 to 8 months of age. One important characteristic of neonatal abstinence syndrome is that it affects multiple systems. Neurologically, the infant is hypertonic, that is very stiff, has tremors, is hyperreflexic, irritable with a very high-pitched cry, can have seizures, and certainly has sleep disturbances. It's not unusual to see that the elbows, the chin, the knees are scraped and raw from the infant's rubbing on the sheets. There's autonomic system dysfunction with a lot of yawning, nasal stuffiness, sweating, sneezing, low-grade fevers, and mottling of the skin. From a respiratory perspective, the infants are breathing fast, that is, they have tachypnea, and they may even have periods of apnea, brief episodes of cessation of breathing. I've seen many infants worked up for newborn pneumonia when in fact they were going through NAS. Gastrointestinal symptoms, diarrhea, vomiting, poor feeding, difficulty coordinating suck and swallow, and ultimately, many of these infants suffer failure to thrive. So the important thing to note here is that several systems in the infant are affected, which when we talk about treatment is why it's difficult to say any one drug to treat the child will cover everything. So the first step in treating NAS is always supportive. And in some studies we did, we found that with good supportive care, we could avoid pharmacologic treatment in the majority of infants. That supportive care consists of swaddling the infant in a flexed position, using a pacifier, low lighting, if available, an oscillating crib, and in nursing care for the infant, avoidance of abrupt changes. Now, this requirement for supportive care has led many NICU programs to develop a special nursery for babies going through neonatal abstinence syndrome. One that I got to view directly is in Alaska. They've done an excellent job of developing a special program for infants going through NAS with their own side nursery. There are several other programs across the country that also have developed this type of nursing care. In that context, the infants will not, remember we said the infants vomit, they spit up, and so they will not tolerate large feedings, so you have to give frequent small feedings. Now, there is at times a need for pharmacologic care. I am not going to go specifically into the pharmacologic care during this webinar because there are this is not designed for physicians, and I don't usually talk about pharmacologic care except with physicians and nurses. So we can, if you have questions about that, we can address those separately. But one aspect of care I do think we need to address is maternal medication-assisted therapy. And I want to talk about that just a little bit because we know if we can get the women during pregnancy on a supportive, effective dose of medication, then they can get off the heroin and they have better outcomes as well as the infants having better outcomes. And the medication we're talking about first, of course, is methadone. I know many of you are interested in buprenorphine, and I will talk about that also. But methadone is really still currently the gold standard for medication assistance for women addicted to opiates during pregnancy. So let's talk about methadone just for a moment. Methadone is a synthetic opiate. It blocks receptors for pain and is highly available orally. So that's why oral methadone maintenance works so well. Now, its half-life is about 18 to 36 hours. And so what you get with a good methadone dose is the levels in the blood will peak at about 2 to 4 hours after the dose, but it lasts for quite a while, which is why many programs will dose once a day. And once a day methadone dosing for pregnant women has been shown to work quite well. Now, there are some circumstances that you have to split doses, and some programs provide methadone every 12 hours, but that's really an individual decision. In 1997, the NIH consensus panel stated that methadone was the standard of care for opiate-abusing pregnant women. Now, of course, that's from 20 years ago, and we really haven't had other medications available until relatively recently. Now, the goal of methadone maintenance or medication management during pregnancy is we want to prevent abstinence syndrome in the mother. Because be aware, if the mother is going through abstinence, it's a good chance that the fetus also is going through abstinence. We want to reduce or eliminate the narcotic cravings, and we want to block the euphoric effects of the illicit opiates. And so the way we do this is by providing a steady state of opiate levels. Now, there was a study from 2002 that showed that the trough levels, or that is the lowest levels, vary quite a bit in the blood, anywhere in a range from 35 to 215 milligrams. And so you have to monitor the woman very closely to ensure that she's getting a steady state. Now, why is medication-assisted treatment preferable? Especially this research comes from methadone maintenance. You decrease the risk associated with needle use, which obviously AIDS, hepatitis C are especially pertinent. You reduce the rate of drug-seeking behaviors, exposure to various drugs that may be in the heroin that the woman is using, and you avoid the fluctuating drug withdrawal. And let me mention here, if a woman does go through withdrawal while pregnant, there is a very high rate of pregnancy lost. And it doesn't matter what trimester the woman is in. If she abruptly stops her opiates, she has a very high risk for losing the pregnancy. And what the research has shown is that we know the most common pregnancy complications associated with opiate use and have found that methadone reduces the risk for all of those complications, including spontaneous abortion, preterm labor, intrauterine growth retardation, abruptio placenta, and fetal meconium aspiration. So there is every indication that methadone is a standard of care that can benefit both the pregnancy and the developing infant. However, early studies showed there were some disadvantages of methadone maintenance. The earlier studies, in fact, showed that methadone, when compared to heroin use during pregnancy, caused more severe neonatal abstinence, more prolonged neonatal abstinence, and higher rates of newborn seizures. And so the question was, why is that happening? And this is where the studies of high-dose versus low-dose methadone maintenance began to be developed. At that time, when these studies were first done, the current average dose of methadone was about 80 to 120 milligrams a day. Research began being developed, and much of our research in the 70s and 80s was research around low-dose methadone maintenance. And at the time, we defined low-dose maintenance at less than 40 milligrams a day during the third trimester. Now, as you consider methadone dosage, you have to realize that use during pregnancy is going to be different than in the non-pregnant woman or in the man. During pregnancy, there's an increase in fluid space. There's a larger tissue reservoir for methadone to be absorbed into. You get higher rates of metabolism of methadone by the pregnant woman. And methadone also is metabolized to some extent by the placenta and the fetus. And so one would think that you would need higher doses of methadone in order to address these issues. So there have been several studies looking at low-dose versus high-dose methadone maintenance. Now, what happened historically is during the 80s, after the studies came out showing the advantages of low-dose methadone maintenance, the standard really became low-dose methadone maintenance. But then arguments on the other side of the equation began occurring, and there were several researchers arguing for higher methadone doses, and in fact, increasing methadone doses through the third trimester. So I want to review some of those studies. Madden and colleagues in 1977 looked at low-dose versus high-dose methadone maintenance. And what they found is if the mother was on less than 20 milligrams a day during third trimester, only 18% of the infants went through neonatal abstinence syndrome. Whereas if they were on higher than 20 milligrams a day, the rate of NAS went up to 63%. A follow-up study by another group of researchers looked at low dose versus high dose, but you have to be careful here. Look at the dose. They defined low-dose methadone as less than 80 milligrams a day and high dose as more than 80 milligrams. And what they found was there was no difference in neonatal outcome with neonatal abstinence score, need for treatment, or the duration of NAS. Another study supported those findings in 2005, but again, look at the definition of low dose versus high dose, and you see less than 100 milligrams versus more than 100 milligrams. And again, they found no difference in newborn outcome, either birth weight, gestational age, or need for treatment. I will say during this period, we were continuing our own studies and went from 40 to 20 and found that if you could get the mother on less than 20 milligrams a day during the third trimester, you significantly improved newborn outcome. We rarely ever saw neonatal abstinence syndrome, and we were not treating babies for NAS for several years during that time. The standard of care in our program was to try to get women on less than 40, watching for chipping and other illicit use, and if possible, less than 20 milligrams a day. But this remained very controversial. So I want to show you a study from 2002, which I really think is the best study that's been done. It's the best study that's been done so far. It comes from Dash and colleagues. They took 65 pregnant women who were on methadone maintenance and divided them into 3 groups based on their daily dose. There were 25 women who were getting less than 20 milligrams a day of methadone during the third trimester. There were 20 who got 20 to 39. And finally, there were 20 women who were getting 40 milligrams or more per day. What you see in this chart is that the babies whose mothers were on less than 20 milligrams did significantly better than the babies whose mothers were on more than 40 milligrams. And it's really, you can see a stepping stone effect. Let's look at birth weight. So babies born with a birth weight less than the 10th percentile, 4% of the babies on less than 20 milligrams, 12% on 20 to 39, and 30%, which is statistically significant, from the babies on less than 20 milligrams. If their mothers were on more than 40 milligrams a day, 30% of the babies had a birth weight below the 10th percentile. Now, how many babies needed treatment for neonatal abstinence syndrome? 12%, 44%, and 90%. What was the mean NAS score using the Finnegan? And what was found that the mean score for less than 20 milligrams was 3, mid-range was 7, and a significantly higher score of 11.5 for babies whose mothers were on more than 40 milligrams a day. And then hospital days went from 7 to 15 to 38. So you can see in this study, they showed that dosage of methadone in the third trimester significantly affects the infant's immediate outcome. Another way of looking at this is through regression analysis, and you can see significant difference between the number of hospital days consistently rises the higher the methadone dose. The NAS score, you see the same pattern. The higher the methadone dose, the higher the NAS score. Now, in the last few years, the question about buprenorphine has come up. And I have to say that this is still a confusing issue. There have been now a few studies published, and I want to review those with you. There was a double-blind, randomized control set of studies, and this is by far the largest, best done study. And what they found was that there was insufficient evidence to recommend buprenorphine over methadone during pregnancy. They just didn't find any of the positive outcomes associated with buprenorphine versus methadone that other studies had looked at. What they did find was that women who were on methadone had a slightly superior retention in maintenance treatment. Another study in 2012, just before that one in 2013, found that buprenorphine may produce less severe neonatal abstinence syndrome. Several other studies in 2013, buprenorphine versus methadone, there was a higher birth weight and larger head circumference with the buprenorphine infants versus methadone. And then the studies that have looked at buprenorphine versus non-exposed infants found that there was no difference in growth patterns, but that the infants whose mothers were on buprenorphine versus non-exposed infants, so these infants were not exposed, hyperactivity, visual motor impairment, and memory problems did occur at a higher rate. So, in summary, the final conclusions are still out. The American College of Obstetricians and Gynecologists does recommend that obstetricians try buprenorphine before going to methadone. But as I showed in the very first study I presented, there really is very little evidence to support that recommendation. So the jury is still out. Before I go to long-term outcome, I want to address a question. It's a rather long question, so I'm going to read the whole thing. I am a foster parent who cares for substance-exposed newborns and infants. Opiate exposure is becoming the most common issue I am seeing in babies placed in my care. In regards to seizures experienced during NAS, are these seizures considered a medical emergency or more of an extension of the tremors often seen? Do the seizures only exist during initial NAS or throughout the first 6 to 8 months or longer? That is a great question. And actually, we did a study that looked at that back in the 70s. Here's what we found. We found that the seizures that we saw in infants going through neonatal abstinence syndrome did not persist. And in fact, we got to the point that we didn't find it even necessary to treat the infants. In the beginning, we did treat infants with NAS who were having seizures. We would treat them with phenobarbital. But we found that those infants didn't do any differently, the outcomes weren't any different than infants who we did not treat the seizures. Now, of course, this is a medical decision the physicians have to address, but we found that those seizures were short-lived. They didn't even usually last the first 6 to 8 months. They usually occurred only in about the first 6 weeks or so. Again, it's an individual decision. I can't recommend whether a baby should be treated or not, but we found that the seizures, in response to your specific question, the seizures are really most related to the acute phase of neonatal abstinence and do not persist. After our announcement about this webinar came in, we did get several requests to try to address long-term outcome. And so I'm going to review some of the studies, some of them going back to the 1970s, but I tried to pull some key studies. Now, here's a caveat. All of the studies so far of the long-term outcome of infants prenatally exposed to opiates, all of the studies are lacking in that they're very small sample size, and they don't really control for the important covariates of environment and other factors that we now know must be addressed. However, here's what the studies have found. There is some evidence of delayed general cognitive functioning at 3 years of age. And that study is from 1979. Let me mention that I have included all of the references when pertinent on these slides. There is some evidence of lower verbal abilities, impaired reading and arithmetic skills, and inattention, attention deficit hyperactivity disorder, and disruptive behaviors. Now, let me mention here that when you look at all of the literature on the long-term outcome of infants exposed prenatally to opiates, And I haven't really emphasized this, but let me emphasize here, we're talking not only about heroin and methadone, we're also talking about the prescription drugs. The common theme is these regulatory behaviors, the inattention, the ADHD, the disruptive behaviors. Most studies do not show any type of cognitive disabilities. And in fact, if the delivery goes fine, there's nothing like cerebral palsy that occurs because of some accident at birth. Cognitively, these children, just like children exposed to cocaine, children exposed to other illicit drugs, global cognitive development is normal. Where they most appear to run into problems are with the regulatory behaviors. Now, we got another question that came in that speaks specifically to this point. The question is, does the acute sensitivity to light, sound, touch seen during NAS appear to persist into early to late childhood as a sensory processing disorder? Boy, these are great questions. And it leads right to the next slide. Sensory processing disorders are an aspect of self-regulation. Now, those of you that have attended our previous webinars, whether talking about fetal alcohol syndrome, marijuana, other substances, this is the model I use to talk about long-term outcomes. I look at the long-term outcomes of children prenatally exposed to substances from a perspective of information processing. That is the way the child takes information into the brain and uses it. And there are three components to this information processing outlook. The first is neurocognitive functioning, and that is global cognitive development, learning disabilities, executive functioning, learning disorders, for example, memory problems. The second area is self-regulation. We'll come back to that. And the third area is adaptive functioning. The ability to take information you have that you know and apply it to daily living skills. Now, if we were talking about alcohol-exposed infants, we would be addressing all three areas because alcohol affects all three areas of functioning: neurocognitive, self-regulation, and adaptive. And one of the things when I work with clinicians, one of the ways I talk about that you can differentiate children exposed and affected by alcohol exposure from other children exposed to other drugs is really adaptive functioning. That's really what sets those children aside from other exposures, but being aware they also have neurocognitive and regulatory difficulties. What we find with a substance such as opiates is most of the difficulties, from as much as we can see so far from the research, most of the research shows that the deficit is in self-regulation. And that's exactly what I just got through showing you from those on that other slide. Self-regulation, looking at emotional regulation, sensory processing, behavioral regulation, which is focusing, staying on task, and often these children are defined as ADHD. A word of caution here, though. We know the most common pattern of drug use in pregnant women is polydrug use. And from our own research, we can tell you that about 80% of the women who are using opiates also used alcohol and tobacco. And so it's very difficult in this triangle I'm showing you right here. It's very difficult to be able to relate anything specific to any one substance unless you have very good control and information regarding the polydrug use patterns. So, what can we do about this? SAMHSA has published this 5-step policy approach for maternal child health. The first step is pre-pregnancy awareness of the effects of substance use. You would be amazed, maybe you wouldn't be, at the number of patients I get who said their physicians told them not to worry about their methadone use during pregnancy because methadone doesn't cross the placenta, the baby would be fine. And then they were all shocked when the baby ended up in the NICU with neonatal abstinence syndrome. So we have to educate not only the public, but physicians and other care providers as to the impact of narcotics on newborn outcome. The second is we must develop prenatal screening and assessment. These are expert systems, and a lot of my current work is working with communities and states to develop systems of screening, brief intervention, referral, and treatment for pregnant women. Associated with prenatal screening, brief intervention, and assessment is treatment. We must initiate the enhanced prenatal services that will respond to the women's needs. The third step is we must be able to identify these children at birth. And again, a lot of work is being done on training physicians, nurses, nurse practitioners, nurse midwives on how to recognize an infant affected by prenatal substance exposure. If that child, in fact, has been identified, then specialized services for the child that ensure the infant's safety and responds to the infant's needs have to be developed. And this is where the child welfare system comes in. And programs for the parent. And let me say that should be parents. We have to address the needs of both parents, men and women. And we have to integrate the systems that respond to the children's and the parents' needs. So this is the overall 5-step policy approach. Here are our challenges. Preconceptually, there is a lack of both public and professional awareness of the opioid effects on pregnancy and the newborn, and a lack of prescription surveillance. I will say that in just the last 6 months to a year, many states have implemented policies now that are instituting surveillance of prescriptions across the state. If you're interested in policy aspects, let me mention that we did publish an article, it was about a year ago now, on the policy implications of NAS. And I'm happy to say that many states have contacted us and have used the policy recommendations we made in that article to implement their statewide policies. If you would like a copy of that article, again, just contact Gabe through our website, and we'll be happy to send you that article. As far as pregnancy, there are few complete expert systems across the country. We have to develop those systems. There are problems linking prenatal and substance abuse care, and I know there are HIPAA regulations, there are regulations addressing addiction and people in addiction treatment, but we have to find ways from a policy perspective to step beyond those limitations so we can communicate between healthcare providers and substance abuse treatment providers. And we need some good, solid guidelines for medication-assisted treatment during pregnancy, whether that treatment is with methadone or with buprenorphine. Studies have shown that in caring for the newborn, using the Finnegan Neonatal Abstinence Scale score, there is very poor control and inconsistency, with very poor inter-rater reliability, poor training of the raters, and a bias among some raters as to how they rate an infant. So what this means is if you go into your local hospital and look at NAS scores, you would be able to see that some, and in this example, nurses consistently rate infants as going through more severe withdrawal on the NAS score than do other nurses. There's no consistency, no reliability between raters. And if a hospital is going to use the Finnegan score, they're going to have to provide consistent and ongoing training with good quality control. The second part of this, when it comes to the newborn, there is no real, consistent, evidence-based approach to the treatment of NAS within hospitals. So you'll see even within NICUs, some physicians will treat NAS with one medication, some physicians will treat NAS with another medication. We have to address this and develop a research-based approach that can guide appropriate treatment for infants. Child welfare comes into play. There is very erratic adherence to child welfare laws. This difference occurs state to state and within states. So some hospitals are much more aggressive in reporting infants going through NAS, reporting those infants to child welfare, than are other hospitals. And almost consistently, it's related to the socioeconomic and racial status of the patients. We published an article back in 1990 that showed the racial and social class bias that comes into play when you combine substance abuse issues with child welfare laws. In the modern day, this has been affecting the implementation of CAPTA. CAPTA is the Child Abuse Prevention Treatment Act that requires physicians and other providers who recognize an infant as having been, and the legislation is in quotes, the infant has been affected by prenatal exposure to substances. That is a mandated report to child welfare for linkage into early intervention. We have found in our own studies that about 85% of physicians and 80% of judges are unaware of CAPTA regulations or the requirements that relate to their own field of work. Finally, for pediatric long-term care, we not only don't have good research to tell us what happens to these infants and children long-term, but most of the research has not looked at the very subtle neurodevelopmental sequelae that can occur. And so we need good long-term evaluation, research, and we have to know the needs of these children as they get older. Finally, this is my own systems approach to NAS prevention intervention. And just very quickly, start at number 1, bottom left, it's in blue, professional development and education. We have to develop programs for physicians. Number 2, above that, public health campaigns. Number 3, surveillance of opiate prescriptions. Number 4, expert services for all pregnant women. If it's negative, it gets recorded in the obstetric chart. If the screen for opiate or other substance use is positive, it must be recorded in the patient obstetric chart. Or if it's negative, if it's positive, a brief intervention must be done. Treatment must be provided or accessed as needed. All of that information goes in the obstetric chart. And then the transfer of information from the obstetric to the pediatric care provider. Now, some physicians and hospitals claim that HIPAA keeps them from communicating between obstetrics and pediatrics. That's just not true. All pediatricians should be looking at the obstetric chart. All obstetricians should be informing the pediatrician, nurse practitioner, family practitioner of the child's prenatal exposure. I have been involved in many situations where I've seen a child going through neonatal abstinence, but getting MRIs and EEGs for seizures, when in fact it was neonatal abstinence because the pediatric care providers did not know that the child had been prenatally exposed to opiates. We need 8 and 9 neonatal monitoring, assessment, and treatment. while adhering to captor regulations. We need long-term child developmental screening and assessment intervention as needed long-term. And of course, state and federal policies have to oversee this over the long term. Now, these numbers refer to points that I make in the article so that you can download NAS publication, the PDF, and the numbers that are in this chart correspond to the numbers that are in that article. So what I've tried to do today is give you an overview of the history of opiate epidemics in this country, the unique aspects of what we currently are seeing, and then the most up-to-date and best information available as far as neonatal abstinence, its diagnosis, its assessment and treatment, as well as the little bit of information we have about long-term outcome. Thank you all for joining us. And certainly if you have any questions, you can contact us at ntiupstream.com. There is a lot of information on there that could be helpful to all of you. Thanks so much.